Thanks, Maca. Thanks, Maxa. So welcome everybody to this session, which is also part of Canadian Patient Safety Week. We'll begin with the land acknowledgement. So Shared Health Services and this webinar are occurring in Manitoba, which is located on the original lands of First Nations, Inuit, and on the national homeland of the Red River Métis. Manitoba's health authorities respect that First Nations treaties were made in these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. So this session is part of Canadian Patient Safety Week, as I mentioned. This year, the national theme is All Voices for Safer Care. And this theme builds on last year's national conversation about broadening how we define patient harm. So often we think about, when we think about safety and harm, we think about physical things like giving the right medications and preventing falls. In order to create safety in healthcare, we also need to work together to promote psychological safety, spiritual and cultural safety as a few examples. And today we're really excited to learn from the panelists and explore what safer care looks and feels like from the voices of patients, families, clients, residents, advocates, and caregivers. I'll just introduce our four panelists. So Morris Favros is a patient and family advisor with WRHA. Morris is from the Philippines and now resides as a visitor in Winnipeg, Manitoba with his wife and children. As a patient and family advisor and PFA council member with the WRHA, he draws from personal and family experiences in healthcare, faith-based ministry, and education to advocate for better communication and compassion in care. In his spare time, he enjoys learning new skills and exploring Manitoban culture. Next, we have Madeline Jantz, who is a patient and family advisor with WRHA. Madeline Jantz is an artist and disability justice organizer from Winnipeg, whose work is shaped by lived experience navigating the healthcare system as a physically disabled and neurodivergent trauma survivor. Marty Goddard is a patient and family advisor with WRHA. Marty is from Winnipeg, Manitoba. He became an advisor after several incidents that occurred to himself and his wife, which instilled a need to assist in creating change in the system. Marty enjoys reading and building and painting military and civilian vehicles. And Sandra Sukan, patient and family advisor with Shared Health. Sandra has lived in Winnipeg for the past 55 years. She served as an advocate for her parents when they needed access to quality health care, her dad for terminal cancer over a 5-year period, and her mom, who was living with Lewy body dementia for almost 9 years. Sandra currently serves on several volunteer boards, including one for racialized older adults, one for 55 plus members, and one as a caregiver patient advisor interested in issues related to access to quality and timely health care. She enjoys continuous learning, travel, and cooking and baking. And last but not least, we have Carolyn Shimon, who is our facilitator today. She's the Provincial Patient and Public Engagement Lead with CHI and Shared Health. And Carolyn, is the Provincial Patient and Public Engagement Lead for the George and Fahey Center for Healthcare Innovation and Shared Health, in case you're unfamiliar with the CHI acronym. And in this role, she leads the development and implementation of patient and public engagement strategies across both health research and provincial health systems. So thanks again, everyone, for coming today. And I'll pass it over to Carolyn.
Thanks so much for the introduction, both Maxa and Amy. And I want to begin by thanking our lovely panelists. I can't wait. Thanks everyone for creating space for this conversation today. Patient safety is something we all care deeply about, but the lens of lived and living experience really gives it meaning and direction. So today is about learning from each other, what safe care looks and feels like, what gets in the way, and what we can do together to make things better. So my role is simply to help guide the conversation, and I invite everyone to share openly, listen generously, and stay curious about each other's perspectives. So I'm going to start out with our first question. If each of our panelists can briefly share about your journey as a person with lived and living experience, or patient or caregiver or community partner, and what really motivated you to get involved in patient safety and care improvement. Maybe I'll start out with Morris.
Thank you very much, Carolyn. For me, my journey started from a place of gratitude and personal experiencing firsthand how compassion and attentive care can transform lives. I have an aunt who used to be a head of the rural health unit back in the Philippines. So she served there until her retirement. And she also works uh, privately when she comes home to serve the community nearby and even towns coming to her riding in carabaos. And we don't, even up until today, the concept of family medicine and community medicine is not well defined in those areas. And access to transportation is one of the most difficult way of getting there, but people would come to her up until today. And she's almost 80 and she hasn't retired yet. So you can see that the passion there is something that I myself really value. That's why I realize that safety isn't just about avoiding harm, it's about building trust and relationships. I wanted to be part of that change, helping ensure every patient and family feels seen, heard, and cared for with dignity. My in-laws here in Canada who are citizens, they always boast about how wonderful the healthcare here in Canada. And when I used to work as a hospital pharmacist, my dad taught me a very valuable lesson I still carry today, which helps me to advocate for voices of people. Most people, patients, and families come with fear, anxiety, and insecurity when seeking care. So, no matter how tired or burdened you are as a healthcare worker, always maintain professionalism and compassion. It's not just about giving options to people, but rather listening to what they are not saying at the moment. Thank you.
Thank you so much for that reflection, Morris. And what an incredible, your aunt sounds amazing and all of your relatives as well. What great lessons. Maybe I'll ask this question as well to Madeline.
Sure. Thank you so much. So I am coming out of this year has been my re-emerging into the world after a 5-year health crisis. Thankfully, I haven't felt in the throes of it for a while, but when it was bad, it was, I really did give up on myself and on accessing healthcare. I jumped from doctor to doctor, a very typical story, and went to many different specialists and felt the, daily terror of not knowing what was going on and not knowing how to find the answer. And for me, yeah, becoming an advocate, it wasn't really a choice. I'm glad to be here, but it was really, I want to survive. I want a good life. And that's what compelled me to start advocating for myself. And, it's just never stopped. I'm here today because of my work, but also the work of fellow disabled, the disabled community, who, yeah, I think we regularly save each other's lives. And yeah, so that's a snippet of my story, where I'm coming from. Yeah.
Thank you so much, Madeline, for sharing and really how much insight you bring to the table when it comes to these conversations and the strength and resiliency. Thank you so much for sharing that. Sandra, did you want to share your reflections?
Sure. Mine is from the perspective of a caregiver. So I sort of fell into the role of advocate when my dad was diagnosed with cancer. And coming from a very colonial medical system, I was used to basically the doctors are the authorities and they tell you what you need to know and you don't ask any questions. And uh, cancer of the lacrimal sac was an entirely new thing to me. Then I first had to figure out what it was. And then realizing that when you hear the word cancer, you as a person with cancer, I think you just don't listen anymore. Nothing else makes sense. So fortunately, I was an educator as well. So, I took my journals with me and wrote things down, my notebooks, and, because then I had to explain to the staff that I'll have to communicate this to the rest of my family, because I don't even know what you're saying. And, I was a highly educated person, but still couldn't figure out I have no medical background at all. So when you're telling me things that I don't understand, I'm going to ask you, like, can you explain that in layperson's language? And so my dad wasn't really listening. He just sort of handed over his care to me, like Sandra will know what to do and say and figure out and ask. And so that started a journey that lasted 5 years. And then after that, he passed, and then my mom was, here, and then she was diagnosed with dementia a few years later, and then that started another journey of learning and just really kind of in that first 5 years figuring out what my role was as a caregiver, and then for my mom, that was a physical thing, and then my mom was a more of a mental psychological thing. So different needs and huge learning curves for me, because I didn't really know how to navigate the system. So it was a lot of learning over the last 20 years. So that's what I'm bringing to this.
Thank you so much for sharing, Sandra. And you really speak to the important role of advocates and caregivers along this journey as well. Thank you so much. And I'm just double checking. One of our partners, Marty, just a little message, Marty. You might be in our audience, but if you check your email, there's a little link that can bring you over here, and we'd love to hear from you. So we're going to move into the second question, and thank you so much, everyone, for sharing your reflections so far. Can you share a moment when care felt either safe or unsafe for you or your community, and kind of what was learned from that, and what maybe the audience could learn from that as well? We'll start back with Morris again.
Thanks, Carolyn. I used to roll my eyes when people ask for more experienced healthcare professionals, but when it was our turn, we have a 2-year-old son who was hospitalized, and it took several tries by younger doctors to insert his IV, and I can see the face of my wife with horror looking at it because our son is already crying. uh, I asked for our child to be moved to a different room for the IV insertion. I was there, and then a senior resident came over to help. And when it was already placed in, I finally understood why experience bring such reassurance for patients and their family. I totally understand that the lack of professional healthcare um, members is a concern, right? But then again, I feel what they have experienced. So that there is an experience for having that unsafe and safe experience all together coming in. I think what I'm trying to convey there is that it needs a connection, the confidence, the peace that must be put together. There's no rushed communication that can lead to fear, confusion, and true safety starts with presence and empathy, not just putting.
Oh, I'm wondering, maybe did Morris freeze there for a minute? That was such good insight, Morris, about your around presence and empathy and that understanding of taking time to really reassure folks. That is such a great, that's really important for people to understand. Madeline, did you want to, while Morris is unfreezing there, Madeline, did you
Sure.
want to maybe?
Yeah, I would love to go. Yeah, so for me, the first couple of years of my experience was the doctors that I was speaking to, it was mostly, I'll speak on emotional safety. So I really struggled at first because I was trying to convey what was happening. And of course, I think I was 25 at the time and terrified, my spine was in pain. And as a young person, not having any experience with back pain, that like, it was like, red alert, what's happening with my spine? It was really, really scary. So I would not really I wasn't able to, you know, articulate myself incredibly well. I didn't have a background in medicine, and a lot of times doctors wouldn't really understand and wouldn't seek to understand, or see that, of course, I would be terrified and my brain would be dysregulated. I would be dysregulated and not able to convey to the best of my abilities. I had a doctor about 3 years in, and she was the one that helped me get on EIA, which was one of the things that ended up really, saving my life and allowed me to get my health back. The difference with her was that she took her role as not only a doctor, but a teacher very seriously. I think something that a lot of doctors miss unintentionally is, knowing, as a teacher, you need to know your audience because everyone will learn differently. And what I really appreciated about that doctor was she saw me as the complex human that I am, that we all are. She saw that I was extremely anxious, jittery, shaking, not able to make eye contact, breathing short, having very short breath. I think a lot of people would interpret that as many different things, or read that as this person is insecure and a little bit of I was a mess, but looking beyond the mess and seeing this person needs somebody, needs to not only not someone to save them, but to work with them. And she did such an excellent job at that, just by seeing me and collaborating. It was collaboration. Yeah.
That's an amazing, thank you so much, Madeline. That's an amazing example of what safer care looks like, all those moments of connection there and education and taking that role seriously. That's so great. Thank you so much, Madeline. Sandra.
So for me, part of it was physical, but part of it was also sort of like psychological. So my dad, when he was getting radiation, his cancer was mostly contained in his head. And I remembered the doctor saying that he needs to get radiation, but like really not knowing anything about radiation because cancer wasn't something we had lived with. And they made this, I'm going to call it like a cage because I don't know what else to call it. And so he basically had to lie down on this bed with this cage over his face that was screwed onto the table so he couldn't move his head. And I don't like enclosed spaces. So my dad is relying on me to provide him with the best care and the best explanation of what he needs to go through. And when the doctor was explaining to me that he's going to have to lie down on this table and he absolutely cannot move his head at all. So this cage is going to be put over his face and it's like molded to his face. And it's got like holes in it, like a mesh cage, but it's basically keeps your head flat on the table. So you can't even twitch. And when I saw it, I sort of like felt this panic because I wouldn't be able to, like, they'd need to sedate me to do that. But I'm now having to try to explain to my dad why this is going to keep him safe. So physically safe for him, but sort of very emotionally traumatizing for me because I'm trying to explain to him why it should be good. But I know I probably wouldn't have been able to do it. The idea that I'd have my head pinned down on a table with this mesh where I could see everything and I'm like I'm wide awake was kind of a little terrifying for me. And I could feel my throat sort of locking up, but trying to like swallow and explain to him that he'll be okay and he'll be safe, when I didn't really feel that. So that was a very like visceral feeling for me, trying to tell him about that he's going to be physically safe, but I'm like not okay with that.
Yeah.
That was that's still very visual in my head. Like it's been 2006, so it's almost 20 years, and I can still feel this sort of like, I need to breathe deeply. So that was just one incident, many over the years.
Oh, wow. Thank you for sharing that, Sandra. And it really points out to the fact that care has to be done to include the caregiver as well, right? And your feelings around trying to say this to your dad while addressing your own fears about it too. Thanks so much, Sandra. And I was just told, oh, and Morris, you're back. I'm glad you're
Yes,
able to make it
I'm
back.
so sorry. The internet
No
went out
problem.
for a while.
No problem. Thanks for rejoining. I'm so glad that you were able to make it back. Um, our next question is around what barriers you may have experienced or seen others experience when trying to speak out about safety, and some ideas around how we could break those barriers. Morris, did you
Oh,
want to start? Sorry.
so I'm just in time again for my turn to share. Um, this one is from the experience of my father-in-law, who recently had to have a catheter placed on his lung. It was so uncomfortable for him when he had that, and one option that was given to him was actually to have an option to stay at home and given a home care as option. But then when he went back for a follow-up checkup, what was told to him was that he can walk fine. So he's considered an ambulatory patient. So he would go in every time to make his follow-up.
We're having some difficulty today a little bit with our internet connection. Um, Hopefully, Morris, you hear us. You've frozen a little bit again. Maybe we'll wait till Morris comes back and we'll move to Madeline. Maybe your reflections.
Sure. Yeah, sure. Yeah. What was the question again?
Thinking about maybe barriers that you may have seen before about speaking out about safety and things that we might be able to do differently.
Yeah. I think for me, similar to what Sandra said earlier, I think she was talking about how we go, when we're newer to accessing, when we're newer to being a patient, I think for me and a lot of people, I thought, okay, I'll go to the doctor. I just need to explain things, lay things out, and then they will have the answers. I will be saved. I will be saved by the healthcare system. And for a lot of people, that does happen. The healthcare system has such immense power, which is a blessing and a privilege. We are very lucky to have that in our country. But it is it's power. It's the healthcare system is also the gatekeeper of treatment, diagnosis, life too. And I think that I didn't understand how that power imbalance would the potential negative manifestations of that when I first became a full-time patient. And I think a big barrier for me was not having the language for that, not having that be acknowledged by others or even by doctors. I know that's kind of an awkward thing to do. It is a tricky interpersonal dynamic, but to go into a room with a stranger and share your deepest fears and traumas it's weird. Like it's weird interpersonally. That is not something that we often do as humans. It's very it's very odd to our nervous systems, and it's odd psychologically, and especially when we think we're explaining things and then we get met with well, just try this medication, or you're gonna be fine. It's extremely confusing, and I think that when that power isn't named, it becomes really, really disorienting, because we see somebody who has authority underreacting to our situation, which is just an inherently disorienting thing to go through. So I think, yeah, I think that to summarize, I guess, yeah, a barrier is not having that power named and not having tools to navigate that trauma. That's when I think disability justice is really powerful. And also, yeah, doctors naming their power. Naming power can soften power. And I think, yeah, doctors who understand, the need to be accountable to that. Those are the doctors that I think I've seen have made just a huge difference in patients' lives. Without that, yeah.
That's amazing. Thank you so much, Madeline, for those reflections. And it definitely really speaks to that need for all healthcare professionals to really have that critical reflexive practice about their own positionality, right? And where they're coming from when they're coming into that conversation. And also the role of disability rights movements in also pointing that out and naming that too is such a powerful relationship. Thanks so much, Madeline. Sandra.
Sorry. I would say that I guess I think that the way I see safety, sorry, I'm just reframing my thoughts here. So
Yeah.
can you just repeat the question so that I'm sure that I'm saying, because I was so focused on what Madeline was saying, I was
I know I was taken into, we were all, we're just thinking about barriers that you've experienced or you've seen others experience when it comes to speaking up about safety, and what might be some ideas on how to break those barriers.
Yeah, so when I think about barriers, I think about more as I mentioned kind of at the beginning, the sort of the authority that we hand over to our medical practitioners. So I remembered the doctor telling my dad that his second round of radiation, he had to have all his teeth taken out. He had already lost an eye and had this big graft on his face, so his face was already quite disfigured. And they said, "Oh, he needs to remove his teeth." So, and I said, like, what does that have to do with anything? And they explained that, well, they were going to give him the radiation, and if he had his teeth in and he got a cavity, it would maybe not heal as well if he had to have it, tooth extracted. And fortunately, I knew my daughter had a colleague, a friend whose dad was a dental specialist, and he said, no, that's what you need to do is have good dental hygiene, which he did anyway. But no, he doesn't need to do that. And they said, oh yeah, he'll have to have a set of dentures, and then he won't have to have dentures for 6 months until his gum shrinks. And I knew a denturist who said that's not the case either. And so just that kind of like taking what they're saying at face value without thinking that maybe there might be some other options. And I was glad that I had done that, because then he didn't lose his teeth and he didn't have to wear dentures. Like, so it wasn't an avenue, but it was kind of like the first solution, which wasn't really a solution. Now he's lost his eye, his face is disfigured, he's got this big skin graft from his leg, and now he's going to lose his teeth. He won't be able to eat. Like, it's not just the physical appearance of him, but psychologically, you've basically disfigured him, and you're going to continue to do that. And I understood that it was cancer, but it wasn't necessary at that point. At least I thought there might be some other options to explore. So for me, it felt like you sort of have to hand over your power to people who know more than you and realize that maybe you know equally as much in a different way. So that I think that's where the advocacy about why my role as a caregiver is important. Like you know this man as a patient, he might be a number or a name, but I know him as my dad, right? So that personal relationship needs to count for something.
Absolutely. And the outcomes that matter most to folks may not be the same as clinicians. So the fact that you felt you were able to express that is so important. And it really speaks to the importance of engaging family in these conversations as well.
And sorry, if I can just add to that, like, when my mom was first diagnosed with dementia and the doctor had given her, like, day one, she ended up in the hospital before she even had a diagnosis. And it was like, well, we're going to start her on risperidone because this is what we think is wrong with her. And it actually, 2 months later, was not what was wrong with her, but she was still on the medication and no one wanted to take her off of it because a psychiatrist had prescribed it for her. And so, well, I'm just her GP, so I'm not going to do that. And then it just became this huge fight about like, well, who's going to be responsible for this? And then and it's like, no, we can't just take her off. If the psychiatrist said to do this, she needs to stay on it. It was completely the wrong medication for someone with Lewy body dementia. At least that's what I was told after. And then she just stopped taking it one day. And it's like, oh, okay. Oh, it has all these side effects and this half-life and this, and she just stopped one day. And that was how she got off of it because she thought people were trying to kill her. I guess in a
Oh,
sense,
no.
the medication was kind of doing that. Right.
Wow.
So that felt very unsafe, but it also felt like, who's listening to me? Is someone hearing what I'm saying? Because she can't speak for herself. So yeah, so that was
Absolutely.
just in terms of my mom's dementia.
Absolutely. That communication piece is so key. And even communication between clinicians didn't seem to be going on as well. So that is such an important, again, the care team, right? And the involvement of everyone. Thanks so much, everyone, for sharing. And I just see that Morris, you're back, which is so
Yeah,
nice to see you
it
again.
doesn't usually happen, but it happened.
It
So this
all
is just one of those days,
Yeah,
right?
it always seems to happen during webinars. Thinking about your experiences, what are some practical ways you think healthcare teams and people with lived experience can co-create safer care together? You started naming some really good ones around communications important and those types of things. Are there other things that you think would be really important? Morris, did you want to start?
Uh, Sandra could start. She's raising her
Sandra.
hand.
Oh, Sandra's. Yes, absolutely, Sandra.
I think, we I come from a racialized community. Most of the people who are in personal care homes are not racialized members of the community. So something like food becomes really important. So my mom is pretty fussy at the best of times, even if you're going to give her great food. But you put her in a place where the food is, they have a 3-week menu, rotating menu, and she has dementia and she's a fussy eater to begin with, and it became really really a struggle to get her to eat, first of all, and to get her to eat what was put on her plate. And then every once in a while she'd say, I don't eat pigs and feathers, and like, so basically don't give me any beef or pork or chicken. And she wasn't vegetarian, but she didn't eat pork. And so, I would go there one day and she's eating a sausage, and it's like, oh, what is this? Oh, it's a sausage. It's not pork, it's a sausage. Oh, I see. It's ham. It's not beef, or it's not pork, it's ham. So did you know that ham comes from a pig? So it was just things like where I really had to talk about her, like her food. This is what she likes to eat. And sometimes when she doesn't eat, so it was more around like psychological safety and nutrition as well. When all else fails, give her a peanut butter and jelly sandwich for dinner. she's not going to eat anything. She won't refuse to eat it, or give her an egg salad sandwich, because that's like her go-to. Food for her was a weapon when we were little. So that's what she used when she was mad. I'm not going to eat anything, and I'm not.
Mm.
So I learned that as a child, but someone who's taking care of her, a healthcare professional, doesn't really know that. So it's like, oh, she's not going to eat. I'll just bring her something else tomorrow. And you know, sometimes she needs to be coaxed a little bit. So I had to keep reiterating that some of the behaviors she is exhibiting are behaviors I'm very familiar with since I was a child. So when she's not going to eat, this is what you need to offer her instead. And it's like when she's going to say, well, I don't eat feathers. Well, they're not serving her feathers, but they're serving her a piece of meat that looks like chicken to her. And no, she's not going to eat it. So
Yeah.
just give her the peanut butter and jelly, and maybe just a little extra dab of jelly, and let her eat the food in whatever order she wants to eat it, or in whatever way. So if she wants to pour milk on her potatoes, because sometimes that's what she did, okay, it's like, really, Mom, that's not how you eat it, but then that's how she wants to eat it. Oh, I want to eat my pudding first, or I want to put my pudding on my mashed potatoes. And it's like, oh, that's gross. But okay, fine. You want to soak your French fries in your coffee? All right, okay. So it was just kind of, when I was a kid, she would soak her toast in her tea. So to her, it was just something she soaks in, that sort of repetitive behaviors. So I really had to explain a lot of her behaviors to them, and then they would say things like, had very graphic and gory visual hallucinations, like body parts under her bed and blood everywhere. And they'd say, oh, she must have grown up in a very traumatic kind of situation for her to be reliving this. And I'm saying, no, actually, she did not. It's just her dementia is making her do that. So don't just assume because her skin is brown and she comes from another country that she must have had this like tragic upbringing that is causing her to have these kinds of gory images in her head. Like, no, this is her dementia. This isn't the life she lived, right? So it was really critically important for me to be able to communicate some of her behaviors that I was familiar with, that wouldn't seem, maybe I'm going to say, normal for a dementia patient, gory images, right? So those were just some of the things that I felt like I could give to, like, as part of the team, I could give my perspective on her care.
Right. And communicating those specific pieces and kind of challenging assumptions that are being made as well. Thanks so much, Sandra. Those are really important practical aspects. Morris, did you wanna?
Yes, picking up from where I was cut off earlier when when the internet went out. Um, it really goes back to options. When you give someone an option, I think it's very important that when you take away that option, you have another ready.
Yeah.
Because in coming from our background, uh,
Mhm.
being polite, being considerate is one of them. So we're not raised up to be more confrontational when it comes to what we want.
Right.
So if that can be done, like for example, if home care is not an option anymore, probably offer like getting rides is difficult, especially if you have family members working. And as for me, I'm a visitor. I'm not allowed to drive.
Right.
My driver's license is hanging on to whether my visa is in process. So I have to renew it all the time. So
Yeah.
yeah, and I think partnering with those in the community, non-government organizations, can work well as part of options, especially if it will serve uh, not just the community, but rather helping out the needs of the healthcare system that is currently, we understand it's hard to fill in a lot of
Yeah.
different positions. So yeah, thank you.
Wow. Yeah, those are really great insights and suggestions as well around partnering with community.
Yes, and it's to add, it's coming from when I was invited to attend a community meeting here at Elmwood. wherein I was asked by the representative to just sit in any table. I was there for my son's uh, what do you call this, food security. But
Yeah.
then I was told just sit on any table, and I was already signed up for WRHA as a patient family advisor. So I choose um, healthcare right away,
Yeah.
and I heard that this is one way of me sharing my voice to help amplify the voice of others as well. So
Oh,
yeah,
that's
thank you.
amazing. Thanks so much, Morris. That's so great. Madeline.
Sure. Yes. Well, this isn't what I was originally planning to say, but I think that one practical tool is actually grieving. And there's a couple of reasons for that. One is, similar to Sandra spoke on this a bit, but we live in a very hostile time. Like the things are pretty scary in the world. What's happening in the US, what's happening all over the world. It's not just, it's happening here too. And I think it's really easy in hostile times, especially when it's not openly talked about very much, the rise of hostility. I mean, it's always been hostile. This is nothing new. It's really easy to shut our hearts off, especially when people are underreacting. And similar, actually, I wrote down something Sandra said. I really liked it. Knowing equally as much in a different way. And I really agree with that doctors have this breadth of knowledge that is incredible to tap into. But like how I see it is I have this very narrow but extremely deep expertise and knowledge on this very specific human experience. And that is something that a doctor, unless they are experiencing that as well, will never have. But I think if we're not actively learning how to grieve, it's really difficult to do things like unlearn our racism and misogyny and ableism, and it's also really hard if we're not learning how to grieve and process things. It's hard to see a patient probably or see a fellow human who has suffered alone potentially. It's hard to see that, but it's also very crucial as well to be able to feel those things fully. Yeah, so that's my thought. Yeah.
I think that's an incredible perspective and thought for our audience to think about and take away as far as patient safety. And I just actually got a message from Maxa that our audience has a few questions as well to add into our. Maxa, did you want to perhaps ask one of the questions?
Yes. First of all, thank you everyone for sharing such lovely reflections and being so open and honest and vulnerable. One
Yeah.
question that we have is, how do you think health system research can contribute to making the health system a safer place for folks?
Mm.
So how does health system research, make people's experiences safer?
That's a big one. Did
So
anyone want to tackle that one? Madeline, I see your hand up.
I could try. I'll
Yeah.
share a couple thoughts as somebody who is not really in the research world at all. I think that one way that it can is to legitimize patient experiences or trends that maybe aren't seen as much because, as patients, especially those who have fallen through the cracks or are traumatized, it's very difficult to have that expertise legitimized. And I think maybe if there's, I don't know, research could maybe, turn that into something more solid, like facts or trends, or
Absolutely.
so that's my little thought. Yeah.
I think that's a wonderful response, and I think that's absolutely true. Sandra.
So mine is actually going to cover both questions.
Oh, look
because
at
I'm
that.
reading them in the
You're,
chat.
you're on
So
top.
yeah, so health system research. So I participated in some research projects of different kinds. And I think one really important point to make is that research participants need to be representative of larger communities than the mainstream communities. So when we're talking about cultural safety, that's a tremendous research project. But what it looks like for racialized communities isn't the same way that it looks for people from mainstream communities. And there are lots of things around barriers to access to care. So health system research needs to be inclusive. And by that, I don't mean just a general, oh, well, we want to get everyone and whatever, but specifically targeted sometimes to populations that are maybe marginalized, that are underrepresented, that are racialized, that come from particular communities. Sometimes like I do a lot of work now around older adults, so volunteer and whatever else. And I think it's just a population we don't really think about. Like, once you get to be 65, you're going to have all these things wrong with you and you're going to be not living a good life. And, when we look at like young old, so I'm defining that as between 65 and 80, we can't lump everyone who's 65 and over in the same. People are living longer. Research needs to look at the young old and then the old old. So I'm considering like people over 80. So I might have multiple comorbidities after 80, but maybe like I still walk a lot, I still ride, I'm very active, I volunteer, I'm back in university again. Like there are many things I'm doing as an older adult that I would like to have someone like to read research on what that means within the kind of communities that I represent. So I think that's how you understand about cultural safety, because what's good for one community isn't good for another. So that's why I'm saying my answer is for both questions, that it really needs to be representative, and that needs to be not like, well, let's just do this research project and by the way we'll have a few racialized people, but it needs to be targeted research with these groups who are oftentimes marginalized. And that's me as a researcher saying that.
Thanks so much, Sandra. No, that's super important that the diversity of perspectives needs to be included in any type of engagement and in any research process as well. That's so important. Just thinking about as we kind of wrap things up, and I think I'll hand it off to Amy in a minute, but looking ahead, what gives you hope about the future of patient safety in Manitoba?
Um, I'll go ahead with this
Yeah,
one. What
Morris.
really gives me hope is, I believe, the growing culture of collaboration, seeing patients, families, and health teams unite with shared purpose, hence the patient and family advisors. So, in a way, there's an assurance for that. But I think we need to raise more awareness for people, how they can participate, so that they can give their voice. Probably the patient and family advisors can take up that role as well within your community. That's one thing. And I believe Manitobans care deeply for one another. And when that compassion drives our system, safer care becomes not just a goal, but a way of life. And that's something I myself is trying to do with my children, because I don't want to lose the next generation thinking, oh, I'm safe. My parents are taking care of it. So I don't have to do anything. I'll sit back until it hits them. It's their turn, right? So we really also have to get everybody involved, including our children, the next generation. Thank you.
Thanks so much, Morris. That's wonderful. Madeline did. Oh, Sandra, I saw your or
Okay, yeah, I think this forum is a good way of getting to talk about what the future of patient safety, like our voices need to be heard. And, if I look at the number of attendees on the list, ranged from anywhere from like 48 to, 50 something. So that's 50 something more people who are interested in figuring out what needs to be, what's going to work, maybe what's not going to work, by listening to our voices. And so just, I think it's sort of privileging our positions, and we're all coming with different experiences, is really what I think is really hopeful for me. So the message I always leave everyone with, and most of my participation in different forums such as this, is like, I'm part of your team. So I'm not separate from your team. I'm part of your team. As a caregiver, I'm an important component. So you have the medical stuff. I have the personal and the psychological and the cultural that you won't have unless you've lived with this person for however long. In the case of my mom, who passed away earlier this year, for 71 years. So the little behaviors you see her doing, you won't understand what that means unless you talk to me. And I'm the only one who she now will even remember. So if you try to give her food to eat, she won't eat it because it's not coming from Sandra. So I'm part of that team. I'm not separate, right? So the fact that you're even having this webinar and inviting us to speak is what makes me hopeful.
Oh, thank you so much, Sandra. Thank you for sharing that. Madeline.
Sure, yeah. I agree. I think conversations like this are crucial. Something that gives me a lot of hope is the disability justice that is happening in the city. There's it's a growing community, and I've seen the magic of it and the power of it. My life was saved because of it, and I think there's so much to learn from how disabled people support each other. And I just want to shout out a book called Care Work. It's called Care Work, Dreaming Disability Justice by Leah Lakshmi Piepzana. And it's a beautiful book on just the brilliance that comes from the experience of being disabled and surviving in this world. And I also just want to leave with a quote, which is kind of on the topic of collaboration and recognizing all of our brilliance, which is "All flourishing is mutual" by Robin Wall Kimmerer. I just think that encapsulates a lot of what this work is. When one of us flourishes, we all, it opens the door for all of us, I think. And that's really what all of this advocacy is about. It's an act of love, really, what we're all doing here. So thank you for having me.
Thank you so much, Madeline. And thank you for leaving us with that wonderful quote and that thought. I really want to thank all of you. Yes, I think you've touched a lot of hearts and really a lot of minds as well in thinking about this. I wanted to turn it over to Amy or Mary Ellen for your final thoughts and your wrap up.
Great. Well, I don't think I can top that. That was just said beautifully, all of you. And I love that quote, Madeline. I think what stood out to me is just the importance of truly listening, understanding our patients and clients as experts in themselves. And as healthcare professionals, we have a body of knowledge and expertise, but the patients and families and caregivers are equally experts in knowing, and we can't provide safe care without partnering with them for care. So that was really what stood out to me. How do we kind of level that playing field so we don't have that power differential that's getting in the way of building the relationships needed to provide the safest and the best care possible. And the quote I had wanted to mention was from our national website, Healthcare Excellence Canada often talks about moving from the absence of harm as our focus to the presence of safety. And I think these kinds of conversations are a great way to move in that direction. So I really want to thank all of the panelists and you, Carolyn and Maxa, for the session today. It was so valuable, and I hope everyone enjoyed it. I'll leave a link to our Canadian Patient Safety Week website in the chat if that's okay. And thanks so much, everyone.
Thanks so much, everyone. Thank you, Amy. And Maxa, did you want to add in any of our, I think Maxa, you added our link for our evaluation as well as our upcoming November 18th session.
Yes, I'd just like to do a quick sum up of the logistics and a pitch for November 18th. We would love if part of patient engagement's practice is to do an ongoing reflective and reflexive exercises. So to help you along with reflection and reflexivity, we would love if you took a moment to write down 3 things that affirmed your knowledge of patient safety, 2 things that you learned about patient safety, and 1 question that you're leaving with about patient safety. You will receive an email asking to fill out a survey about this session, and we would love to see your responses in that. You will also be receiving a follow-up email with further information on how to access the slides and recording. And I just would like to take a moment to thank everyone here. Thank you. It was such a joy working with you over the past couple of weeks, and it was such a joy to listen to your really thoughtful, meaningful answers. And I think we've all walked away with so many answers, but also so many things to think about. So thank you again. On November 18th, which is a Tuesday, we have Race, Ethnicity, and Indigenous Identity, Manitoba's Approach to Data Collection and Governance, which will explore Manitoba's framework for collecting and managing race, ethnicity, and Indigenous identity data. It will explore how anti-racism approaches influence the collection, interpretation, and use of data, and it will explore participatory race-based data governance in practice. The learning objectives will be to gain insight into Manitoba's methodology for collecting and governing race, ethnicity, and Indigenous identity data, to understand the impact of applying an anti-racism lens to data analysis and decision-making, examine the implementation of participatory governance and its impact on decision-making and community engagement. And that will be hosted by 3 very talented speakers, Natalie Busey, Amanda Fowler Woods, and Jillian Warwick. So we look forward to seeing you on November 18th. The registration link is in the chat. We look forward to hearing your 3, 2, 1 reflections, and we thank everyone for coming and participating as panelists and as an audience. Thank you.
Thanks so much, everyone. Take good care.
Thank you.